afternoon, and thank you so much for joining us for this demonstration today. I would like to introduce our gold level exhibitor, Mindsigns Health. They are based out of Arizona. If you're not aware of what Mindsigns Health does, they build the AI stack for concussion care, uniting hospital-grade EEG analytics and behavioral monitoring into one secure, intelligent platform. So here to spearhead the demo is CEO and co-founder Michelle Birnbaum. So I welcome Michelle into the webinar, and we'll have a 20-minute demonstration, and at that time, then we will have 10 minutes for Q&A. So thank you so much, Michelle, for joining us.
Thank you very much, Lisa. Hopefully everybody can hear me. Can you hear me, Lisa? You're the only one I see.
Yes, I can hear you.
Thank you. So good morning and good afternoon, good evening and good night. I think I covered all the continents now. I'm really happy to showcase what we're doing at the Mindsigns. We've been developing this for quite a while with clinicians. So we didn't sit in our corner developing this and then try to fit it into the workflows. We actually developed this from day one with clinicians. So I'm going to share a few things during this presentation. One, I'll go through a set of slides, and then I'll actually demo our products. So Mindsigns, okay, let me bring up. Okay, there we go. Tick. Yeah. Tick. Okay, good. So let me just bear with me. Technical stuff. Okay. So Mindsigns is it's a neuropsychiatric platform, and on this platform we have two main products and actually three indications. Okay. So the first product is a concussion care, as Lisa mentioned during the introduction. And again, we've developed this with a number of clinicians working on concussion and TBI, working with athletes as well as non-athlete patients. And so this is based on the concussion care is based on SCOT-6. We've adapted SCOT-6 to be able to remotely monitor the symptoms and the symptom evolution of concussion. Okay, which is one of the when you speak to any clinician, they'll tell you one, it's very difficult to bring the patient multiple times into the office to the cognitive impairment care. Also, what we do is we look at background slowing, and that's I'll go through those products as well, which is one of the hallmark biomarker of concussion is that background slowing, which hopefully is temporary, but when it's not, and when symptoms evolve in the wrong direction in terms of trends, then the patient develops what we call post-concussion syndrome, which can be really debilitating in terms of day-to-day function. So we have a number of, as you can see, we've developed a number of screens for concussion, both from the patient side, where we have a lot of screens actually, and from the clinician side. So from the clinician side, we're working with a number of, like I said, with a number of specialty center. We're also going to be working with one of the large universities on the West Coast to monitor their athletes. And what's interesting actually, well, is the fact that women are twice as prone as men to suffer concussion, and it can take up to 3 times as long for them to recover from a concussion. And it's physiological, right? It's in terms of the neck muscle, they have a weaker neck muscle. And one of the things in concussion, so I've had concussions because I played rugby competitively and I played soccer, is it's not getting hit straight on, but it's actually the angular momentum that stretches, axons and neurons. And that's when you start having the concussion and the background slowing because your brain hits the back of your skull depending on how you get hit. So for example, some people can get hit at 20, 30 Gs like me, and I'll get a massive headache. But if I get hit at a higher G, then I'll get the concussion. And but for some other people, again, depending on their physiological makeup, they may start getting a concussion at 20 G. Okay. So we're able to measure all that and we follow the patients all along. So we have voice powered assessments. It's very multimodal. This is depending on the patient's choice. They can either use voice or they can enter it manually depending on how they feel that day. You know, some people may not one day they wake up, they may not be in the mood to use their voice, so they can just text and use graphics, and it's very easy. It's sliders, a lot of different graphics that are easy to comprehend. There's nothing esoteric. There's no jargon in there from the patient's point of view, right? And as you can see, we also have medication adherence, and for patients that have comorbidities. So, for example, we were at the John Hopkins Symposium this past week, and there were people with that both concussion and they were developing other comorbidities with mental health issues. So we have other modules that we can bring in and out of the patient side, like a safety plan. We have a medication adherence and compliance, which is very important in certain indication, and I'll talk about that later. And then obviously we have the cognitive assessment. So again, like I mentioned before, it's based on SCOT-6, which is a 48 to 72 hours post-acute incident. And we've adapted this. And again, we've worked with a number of specialty centers developing this so it fits not only into the workflow, but it also mimics what they do with basically pen and paper, right? Trying to bring the patient in. And the issue is a lot of time the patient will say, you know, nobody's listening to me. You know, I have these symptoms, which are not necessarily generalized with the rest of the population, of the concussion population. So that's one. The other thing is, as soon as they start feeling a little better, then it's very difficult to bring him back in. And 25 to 30% of these individuals start developing post-concussion syndrome, which, as I mentioned before, is very debilitating in terms of being able to focus, being able to drive. Uh, Basically, it affects your day-to-day functioning. So those are, I'll just run through them. Those are all the various cognitive assessment. And this is some of the patient dashboards that we use, right? It's summarized. We do a summary. And I mean, we're talking to the NIH. Actually, we're putting in a submission to the NIH in September. And one of the things they said is we like the fact that you basically give behavioral nudges. We don't try to change behavior because I've been doing this long enough to know that you don't change people's behavior by just saying, I want to change your behavior. You have to show them things that are actionable from their point of view. And that's what we do. We give little behavioral nudges. For example, sleep. We show them if you sleep a certain number of hours and the quality of your sleep is like this, then this is what happens to your mood and other attributes within the your behavior. So this is the clinician status, right? So this is specifically for concussion. So if you look, as soon as the clinician opens their side of the app, there are four colors, right? Red, orange, green, gray. The red means there are two patients that need attention, okay, because they're trending the wrong way, etc. Three is up to you to decide. Four is no issue. And five, and the gray ones, which is five, means there's five patients that have not, although they've been scripted, the use of the app, they haven't fully onboarded yet. Okay. So if you decide that you want to click on one of those, then it opens the entire patient that are under that particular color. And then you click further onto a specific patient, and then it opens up all their various metrics. So the recovery status, the physical symptoms they're experiencing during that week. And then we do this on a daily, weekly, and monthly basis, and then the cognitive scores and symptoms that they experience. So the other thing is we look at negative symptoms, and so negative symptoms, as you know, most of you know, are really the debilitating symptoms because there's no real medication that can be given for negative symptoms. On the psychosis side, which are the positive symptoms, there are antipsychotics, Gen 1, Gen 2, etc., with various side effects. But on negative symptoms, it's mostly it's talk therapy, rapid eye movement therapy, etc. So we were able to monitor those outside the office because one of the things that when you talk to any therapist, psychologist, which are mostly the people that do the day-to-day work as opposed to a psychiatrist, which is mostly about following the treatment regimen, making sure the patient is following the treatment regimen. Once my patient leaves the office, I have no idea what's happening to that patient. So what we do is we try to capture that information that everybody knows is on the outside and present it both to a patient and to the clinician in a series of various dashboards, which I've gone over. And here, again, it's very summarized for the clinician because we don't want to overload. There's already enough of a workload on the clinical side. So we show a summary. Then up to the clinician to decide whether they want to know more about a specific symptom. And then they start clicking through that specific symptoms and it opens up other dashboards. So again, this is a summary, again, for the clinician on the concussion side. So the physical symptoms, how it trends, which symptoms are presenting, which ones are not presenting anymore, which may be a positive or it may not be a positive. But again, we're not trying to diagnose anything. We're just providing the information to make a better decision, to make a better treatment decision or a change of treatment. So basically, we're a clinical decision support system, right? And then we have recovery status. And again, on the physical symptom side, as you can see here, we provide different sets of information on what the patient is feeling on that particular reporting period. So the concussion, we wouldn't be able to do concussion if we didn't have two pillar two pillar products. Freudian slip on the investment side, sorry. So we have the NeuroBrowser, which is an automated EEG interpretation system. Okay, and that we've been developing that for quite a while. It's been fully validated and test bedded in Singapore across the various clusters, health clusters, including Sing Health and NNI, which is the National Neuroscience Institute, which is the reference institute for neurology in Southeast Asia, and basically they put us through the test bedding both in ICU environments and ambulatory environments. Okay, and now we're doing the same with one of the top 5 hospital in the US. Again, doing the same thing, basically demonstrating that we have the same performance from in Singapore that we will have in the US. And so far, so good. And we will be submitting to the FDA in Q3 of this year, again, as software as a medical device 510(k). So those are the various screenshots of the NeuroBrowser. So as you can see, for those that haven't seen a trace of an EEG, it can get pretty complicated, especially if you start presenting a lot of the different abnormalities that an EEG detects. So an EEG, for those that are not that familiar, detects electrical abnormalities in the brain, whether it's a seizure, whether it's a spike, whether it's slowing. And the way I like to explain it is a seizure is an earthquake, and the spikes are the aftershocks. So to be able to detect seizures without doing some, hand clapping, loud noise to try to trigger seizure in a patient, you need to do at least a 24-hour to 48-hour study, right? Otherwise, you may detect spikes. So spikes, because it's an aftershock, it tells you that an earthquake has happened. It just doesn't tell you when or where within, the hemisphere of the brain. So actually, what we started with spike because they're very difficult to detect. They're very transient. They're about 70 milliseconds, so they go straight up and down. And then the slowing. So the slowing is particularly used not only in concussion but also in places that don't necessarily have infrastructure. They use it as part of a differential, right? So encephalopathy, brain bleeds, etc., can be detected by slowing, or at least it gives an indication that something is happening that's abnormal. So you can do a lot of different things. Again, this was developed with neurologists and epileptologists that wanted to see certain things, and there's plenty of nice software out there, excuse me, except that there's a lot of high false positive rates. So when we did the test bedding in Singapore in the ICU, we're about 20%, 20 points better than the market leader, the pure software market leader, which I won't name. So we're at the 83% in terms of detecting seizure, both, especially the subclinical seizures, right? Because in the ICU, a lot of patients are immobilized, sedated, etc. So you don't necessarily see that something is happening because they're mostly immobilized. So we came out at 83.2, as I mentioned, and the market leader came in at 62.3. So we were far better in terms of doing this. And it's because of the technology that we use to detect the various abnormalities. So those are seizures. So we can detect on the few channel. Obviously, a seizure, even if it starts focal, eventually becomes generalized, but we can detect the focal seizures that happen on 3, 4 channels, which then indicates to a neurologist or an epileptologist where things are happening with an individual. And then we provide an events list. So if you don't have the time to go through everything, just put the events list. We tell you where it's happening on which channel, how long it's the duration of it, and the various montage that you can have, and then summaries. We give you a heat map of the various abnormalities, which is almost like a balance sheet. That's an instant in time what's happening to the patient, and then we give you the trends and we help you write the report. Okay, and that report is customized for you. So this is a QR code if you want to find more information. And now what I'm going to do is I'm going to actually show you the products that we have. So I'm going to start with the GenMind, which is the mental health product. So just as a intro to what GenMind does. So GenMind was originally developed for schizophrenia. We still use it for schizophrenia, obviously. So we detect negative symptoms and the cognitive impairment that's usually comorbid with it. So now, if I know how to do this, I will go to, yep, here we go. Is it working? Mm. Huh? Technical glitch. Hold on. Bear with me. Working. Hmm. Okay, I'm not going to waste the time. So what's happening is we're going to show you the workflow for the MTBI. So basically, we have a lot of different workflows because again, it's very modular. So we have different workflow, we have different modules, so we can pluck out, put in, etc., depending on the indication that we're working on. So for those that know what negative symptoms are and the fact that they're transdiagnostic. Actually, we've been approached by a number of centers that work on bipolar because in bipolar, negative symptoms present as well, except they're more transient because of the cycling that individuals go through. In schizophrenia, they're pretty stable once you've been able to stabilize them, right? They're pretty steady over time. Whereas in bipolar, they come and go because of the cycling. And when the patient comes in and you ask, about the negative symptoms, there's a lot of recall bias, which makes things more difficult from a treatment point of view. Now, one thing that's interesting about negative symptoms is they present about 70% of the time before psychosis. So there's a lot of interest on early psychosis episodes. And actually, a bit like diabetes, people that are pre-diabetic, you want to manage their glucose levels so they don't tilt into a type 2 diabetes, which then becomes a chronic disease, right? More or less. In schizophrenia, if you go into a psychotic episode, then you become chronic. You have the full-blown psychotic negative symptoms and cognitive impairment. Um, so I'm sorry that there's a glitch here. It's not working, so I don't know what's happening. Voila. Hopefully the next one's going to work. So this is the NeuroBrowser. Um, so here we go. So this is the actual NeuroBrowser. It's in the cloud. So as you can see, it loads real fast. Uh, okay, for some reason it's not. I don't know. Maybe the bandwidth is. Let me see if I can do it from here. Oh, here we go. Okay. Yeah. So as you can see, we have. I can mark things, or I can let the. See, we have the modules right here, the various module spikes, slowing seizures. We have different montages, and the montages change real fast. Up. We have also sensitivity, right? We also adapt for the various thresholds in terms of the polarities. We can introduce EKGs because a lot of times when you do an EEG, you may want to see also the EKG, so we can introduce that in. We have an artifact detection because there's a lot of artifacts, especially in the ICU, from chewing to lip smacking to the noise of a vent, right? If somebody is on a vent, we have the notch filter. So the notch filter is so if you'll see if I take off the notch filter. Right? You can see there's a lot of AC noise, right? So we have this notch filter. So because this is data from Singapore, it's at 50 hertz, whereas in the US it's 60 hertz, and we have that as well. Um, and
So
I'll stop
Michelle,
there. I'll
uh,
stop
uh,
there.
yeah, thank you so much for sharing this. I did want to save some time for questions because we do have some coming in through the channel, and this is fascinating. I would love to speak to you more about this, particularly about the negative symptoms.
Yep.
But
Love
one
to.
of the questions that came through was how do you measure the G impact number in real time while someone is playing sports?
Okay, so the first phase that we're doing with these athletes, it's about 45 to 50 athletes across different contact sports. And as I said before, men and women. We've built a headband because during practice they all wear headbands, especially on the west where it's pretty hot. And within the headbands we have a 9-axis accelerometer, including a magnetometer that measures the angular rotation, and that's how we measure the impact in real time. So the thing is, like I said, some people may not have a concussion at 20, 30 Gs, others may. So the protocol that we're using is as soon as we see there is an impact, regardless of the G, then we put them on the EEG, 15 minutes, that's all we need, and we can see whether the slowing that's presenting or not. So that's one of the protocols that we're using.
Great. One of the other questions, how do you balance giving patients more self-awareness while avoiding over-monitoring or anxiety about their symptoms?
Yeah, great question. I mean, that's one thing that we're very careful about. And so if you look at our dashboard in more detail, you'll see that down to the word that we use. So we work with actually two psychotherapists, and down to the word because we don't want to trigger anything that's not there, right? So we're very careful about that, especially when we have a module on suicidal ideation. So that one, it took us a long time to develop this to make sure that the wording that we use is doesn't trigger anything, right? And we have safety plan, as you saw the safety plan. And in terms of the anxiety or stress of the monitoring, um, that's the other thing that we spend a lot of time on because, as you know, a lot of digital apps, they get used for a month, 2 months, and then they get put in the drawer, right? So I mean, we did that in Singapore. Now we have to show that it works that way in the US, and that's part of the NIH grant that we're submitting is a phase one where we're going to match what we've done in Singapore, which is about 75 to 80% accuracy in detecting and monitoring negative symptoms and cognitive impairment. But again, we ask for consent every day. A lot of people are telling us don't ask for consent every day, but we want to because a patient, depending on where he or she is on the spectrum, will feel different from one day to the other in how they want to provide information. So we give them a lot of latitude in how they use this. They can answer only one question, for example, in the morning check when they first turn it on. That's fine. We'll just ask a bit more questions later on. We just want to get an overview of the patient's mental status, show that to them, but also show it to the clinician. And then up to the clinician to decide whether they want to use that information or not, or keep it until the next time the patient comes in, because they'll have already quite a bit of information.
Wonderful. Thank you. So we have another comment here, obviously excellent product and talk. But one of the questions is regarding the addressing the variability between the modeling. So patients who were, per the report, symptomatic and functioning well below their own baseline, but who were still testing within the normal population range.
So that's for which one? For the concussion or for
And
schizophrenia?
that's what actually, I, Nicole, if you are able to put that in, I don't know.
So
I
for
would
negative
suspect
symptoms,
that it would
yeah.
be negative symptoms, but
Okay. So
that's just my assumption.
for the negative symptoms, as you saw, there's we provide summary screens, right? And this so there is on the onboarding there's a baseline, right? So one thing that we don't do at this point in time, we don't diagnose, okay? And it's mostly from a regulatory point of view because that's a much higher threshold. I think, there's a product market fit right now for being able to provide a set of information that the psychiatrist or the therapist or the psychologist don't necessarily have because it's information that's out there, right? But when they do onboard the patient, they help the patient with the safety plan, and we have a lot of other things. We have, for example, a database where we provide, again, those little behavioral nudges. There's a baseline that's established. Once that baseline is established, then it's shown in that summary, and then we show the trends on a weekly, monthly basis. Uh, and then you can see where that baseline started and how the patient is evolving, either positively, stable, or negative.
Okay.
I don't know if that answers the question. Uh,
Yes, she clarified, just trying to ask about people who test out of the testing in terms of precision care.
Okay. Okay. All right. Very good. So that's one of the things that I mean for all of us on the team, as people use the app more and more, then the app starts understanding how that individual reacts to certain inputs, to certain triggers, etc. And then over time, the algorithms learn, right? So we use machine learning, we use deep learning, we've done LLMs, etc. We only use them as necessary. Okay, not one of the. We even use good old-fashioned statistical methods, right? Whatever works to provide insights. It's not about using the best technology. It's about providing the right insight to both patient and clinicians. So hopefully we get to better outcomes, right? And better outcomes. So for example, on the NIH grant, the better outcomes is 10% improvement in functionality. That's
Mhm.
it, because
Right.
that's already a big one. So I mean, that's one of the things that we're shooting at is precision medicine. So some people will test, I mean, some people will also try to game the system, right? So we use digital phenotyping on top of what we do here. So EMA, what's called EMA, ecological momentary assessment. And so we use that as a kind of a wraparound to the various dashboards that we have. And then LLM, as I said, so we've developed an LLM last year to see in schizophrenia, just using speech, if we could mimic the performance. And actually we could. We
Great.
get to an 81% accuracy, but 81% is as good as what we had already. So it wasn't adding anything. So we're not including it until we can get something else out of it, right?
Great. Thank you so much. And Michelle and Kevin, this has been a fabulous presentation. We are at time. I encourage everyone on the call, please go to their booth. Look at the other exhibitors as well. We've got phenomenal products here. So once again, thank you, Michelle
Thank you
and
very much.
Kevin, for being a gold sponsor, and enjoy the rest of the conference.